Thank you for joining me today for our COVID Comms cast. I'm Kirsten Bruce, Principal of Viva Communications. And today I'm speaking with a Medal of the Order of Australia recipient, Professor Stephen Clarke. He's a medical oncologist, a pharmacologist, a translational researcher, and a professor of medicine at the University of Sydney. His research involves gastrointestinal and thoracic cancers, and he has more than 320 publications to his name. Today, Professor Clarke will share his insights on clinical practice during COVID-19, explain the impact of the virus on cancer diagnosis and treatment, and reflect on the current mental health of cancer patients moving forward. Well, welcome, Professor Clarke. It's so lovely to see you.
Same here, Kirsten. Nice to be with you.
I wanted to ask you how coronavirus has affected your day-to-day clinical practice.
It's affected us quite a lot, really, a lot more in preparation than in actuality, because fortunately Australia hasn't had much coronavirus, but we really had to cater for the worst possible scenario. And the main difference has been mainly doing telemedicine, trying to prevent the patients from being exposed to us and vice versa, and really having to prepare for a scenario where there might be infection in the practice or in the hospitals in which we work.
And how have hospital oncology departments adapted to the COVID-19 environment?
I think probably the same as everyone else, but we worry more about our patients because they're immunosuppressed from some of our treatments. And we thought, and there was a case in Melbourne that we all saw where some of the patients got COVID-19 and they did badly. So we were really worried by that. So we really had to try and reduce the risk of exposure of the patients and also the risk of exposing ourselves so that we wouldn't then transfer it to other patients.
What innovative measures, if any, have been introduced to reduce the risk of oncology patients contracting coronavirus, and will these measures remain in place?
I think to a certain extent, yes. So some of the measures we've introduced, and they're probably the same at other centres, but I can only talk to where I work. We've greeted all the patients at the lift in our practices, and they are all assessed for any potential exposure to COVID-19. They've all had their temperature taken, and if there is any risk, they're turned away. If they're okay, they're allowed to come the next step, which is up to the actual room. For those that we have just been interviewing, we've been doing a lot of telemedicine. So we've been doing Zoom meetings, we've been doing teleconferences, and fortunately the government has come to the party by providing provider numbers for those activities. And the patients have actually quite enjoyed that and felt much safer doing that type of activity. We've also worked in teams and made sure that if one team was out, that there'd be another team that could come in. So we didn't want everyone potentially infected at the same time. And we've done that with our chemo nurses and inpatient groupings as well.
How has COVID-19 impacted the diagnosis and treatment of oncology patients over the past few months?
We've had fewer patients because the surgeons haven't been undertaking semi-elective surgery or cancer surgery as much as previously. So therefore, we've had fewer patients in the adjuvant setting, and we've also probably had fewer advanced cancer patients. In other ways, it's really been the sort of things that I've mentioned in terms of social distancing in the way we see them, making sure the patients are spread out in terms of time slots through the chemo suite, and really trying to avoid exposing them and us to infection.
While clinical trial enrolment has been postponed, what's the status of patients who are currently participating in clinical trials?
So they've continued where you've been able to, but we've stopped new patients being enrolled on study because we didn't want any compromise.
And when do you anticipate that will lift?
I think they're all starting to lift now. We've been seeing patients face-to-face this week. We've gone back to having a single nursing workforce rather than teams. And we're trying to see whether that's going to be okay. If there's any risk, we'll go back to our systems that are now quite well established and have probably been advantageous for us for the future as well.
How has the government's recent easing of lockdown restrictions affected the diagnosis and treatment of oncology patients?
Well, they're feeling a bit safer in coming out, so they're happier to come in to our rooms to see us. They were a bit nervous previously because they were worried about being exposed to somebody else. So the patients are now happier to come out, and the government recognition that it probably is safer has reassured them to a certain degree. It has also enabled the surgeons to start undertaking more surgery, and therefore our patient numbers and referrals will start to increase, and we'll have access to clinical trials again. So we will gradually come out of it probably wiser than we were before, and with new innovations. The telemedicine has been really good for us because we'll be able to offer our services to patients in country centres or in isolated centres where they previously haven't had as good access to medical oncology services. And we will stop patients from coming long distances to see us. We will either do them by Zoom interviews or on the phone and enable them to stay in their normal place of residence.
Anecdotally, how have your oncology patients been coping with the COVID-19 pandemic?
I think the isolation has been reassuring for a lot of patients, but it's also been emphasising, particularly those who have got illnesses that we can't cure. They're realising that they're missing out on some of their bucket list of things to do. So a lot of them have travel plans, they want to go places, see people, see their relatives, and that's not been possible. So we've had elderly patients who haven't been able to see their grandchildren and see their sons and daughters, particularly if they're remote. We've got people who are originally from parts of Europe or other places overseas who haven't been able to catch up with their relatives. And I think they're all worried that they're not going to actually be able to see people and do the things that they really wanted to do. And they're worried that this is going to be the quality of the rest of their life. So I think that's been pretty stressful overall, although we haven't seen any people requiring acute psychiatric care, but I think it's preying on the minds of many of our patients.
So some patients are okay, but others are clearly struggling in this environment.
Yeah, and they're worried that they're going to just miss out on things that they wanted to do.
Have you noticed a shift in the focus of oncology research due to COVID-19? And has the virus shone a light perhaps on any areas that require more attention?
Look, I think it's highlighted a whole lot of areas that we need to attend to. I think on a non-oncological basis, I think we really don't know what adequate PPE is for us and the community. And I think that should have been studied by now. We should know what you have to wear to not infect people with illnesses in general. I think the same thing with our clothing and even things like our mobile phones. Should we be having those, or are they potential risks for infection for us and others? So I think that needs to be studied. I think we're also aware that there really hasn't been a mechanism of how to fund an immediate evaluation of a new treatment so that we can start to rapidly undertake an assessment of new drugs that might be effective against COVID or anything else acutely. And I think the NHMRC needs to look at that, or maybe the Cancer Institute in New South Wales. How do we get a trial up and running really rapidly so that we can evaluate essential new drug treatments or even essential new investigations of safety of equipment? And that's something I hope comes out of this, an ability to rapidly undertake assessments.
As we begin our journey out of COVID-19, what's your advice to those Australians who are living with cancer who may have ongoing concerns regarding their potential exposure to the virus?
The federal government and the state government have performed incredibly well in this circumstance. When we see the experience overseas, I think we're really lucky to live in Australia, because I think their interventions have helped us avoid some of the situations we've seen in Italy and the UK and the US. And I think it's also emphasised how good Australian medicine is. I think particularly our intensive care medicine is excellent. I was asking some of my colleagues yesterday, what's the status if you do get sick to the point where you need to be ventilated in Australia? What with good intensive care is your outcome? And basically our patients have done pretty well, which is in contrast to places overseas where they have less good intensive care. So I think our patients can be confident in the medical system. I think we can be confident in our public health systems. And I think they can be relatively reassured that there don't actually seem to be many cases around of COVID-19. Those cases that do exist, we largely can track and look for exposure of others. I think there have been a few cases this week in schools where there haven't been obvious contacts as to how some of those young kids got COVID-19. But hopefully if there are isolated pockets of infection, we can control them and stop the community from being infected in general. I still think that creates an interesting scenario for the future is, how do we get out of this and how do we start traveling? Because other places overseas will have had the exposure that we haven't. They'll have some degree of immunity and we will not have that circumstance. So I think we still will be waiting for some form of vaccination or preventative treatment that will enable us to travel again in the future, to interact with people overseas, to go and attend conferences from a medical perspective, all those kinds of things we still really can't plan for at the moment.
And finally, as an oncologist, what's your major learning from the COVID-19 pandemic?
I think the main key learning is live and work in a good place. And I think also live and work in a place where you've got reliable politicians who are reasonable people and not he-men, because I think it's been all those places where the he-men have been that the community's done badly. You know, the number of deaths in the UK and the US to me is unacceptable. I think they should have realised that they weren't impervious to this type of thing, and I think they should have acted faster, as was done in Australia, to prevent the community. I don't think you can sacrifice a whole elderly population and a relatively large number of other younger people just in terms of protecting your economy.
Well, thank you so much for joining us today, Professor Clarke, and for sharing your knowledge and expertise and, of course, insights on COVID-19.
And hopefully we won't learn any more about it, Kirsten, because we won't see any of it.
Let's hope so. Thank you.
Okay, see you later.